Hello, everyone. I'm delighted to be here and be part of Pancreatic. I'm going to be presenting on cystic fibrosis and related to nutritional status and impact of the new drugs. I'm Virginia Stallings from Children's Hospital of Philadelphia. And here are my disclosures. And the overview of the talk really is to focus on a couple of things. One, the new CFTR drugs and what that is meaning to clinical care nutritionally, and then a bit about pancreatic function. And then I'll be closing with some comments on a new structured lipid treatment that's available for CF and other fat malabsorption diseases. So in the way of background for this, the CFTR modulators have been with us really about 10 years now. Ivacaftor was first introduced and for patients with the classic gating mutations, that's now up to 96 mutations and represents about 15% of the patient population with CF. Currently, it's approved for use for patients as young as 4 months and older. The other drug that is of real clinical significance, and I'll spend a bit more time on it as well, is the triple combination drug called Trikafta. And it's approved for people with a delta F508 mutation, which, as you all know, is the most common mutation, even as either homozygous or heterozygous. And it's approved for 6-year-old patients and older. And the question really had been, what is going to be the impact of these drugs on growth failure in children and the weight status in adults with CF? And if there's a general take-home message as we've gone through this decade, we almost always see weight gain, as well as the pulmonary function improvements, which are the primary outcomes. And in some settings, we see in some children on some drugs gain in height or stature. There's still an uncertain impact on dietary intake and dietary pattern, but just to mention, these drugs are all fat soluble. So the directions actually include taking in the medicine twice a day with fat, and it seems to be having an impact to improve the fat intake. So now really in the CF community, there has arisen the need to balance two issues. One, we still need to focus very much on preventing growth failure or preventing malnutrition, underweight in adults. And now the added concern and really anxiety in some way about, are the patients going to get overweight? And this is being expressed by both the patients and the nutritionists in CF clinics. So as I mentioned, ivacaftor really is the best example to follow. And now when you think about this, studies for implementing the drug as young as 1 month, which would be right after diagnosis, and the potential for patients to be on this for a lifetime. This was the best match. This drug with these mutations gave the most powerful change in clinical outcomes, pulmonary and GI. Almost everybody gained weight. There was a statistically and clinically important improvement in height velocity in children who were still growing. We and others helped establish the mechanisms for this: decreased resting energy expenditure, decreased gut inflammation, and improved fat malabsorption. These also went on to show that in other studies, there was an improvement in gut pH, a decrease in gastric reflux, and at least in some mutations, an improvement in the bile acid status. So overall, we're getting better fat absorption, better energy balance, which is really leading to better weight status. And to use this slide, again, an ivacaftor slide, to show you the progression of the weight gain in the box here outlined in red, you see the change in weight in kilograms over the 48-week trial. And the blue is the drug and the black line is the placebo. And here you can see a pretty steady weight gain, at least through week 16 and maybe 24, and then generally a plateau. So this is what we're experiencing, and we know the impact of the drug is very rapid. And then I think part of what we're seeing is as the patients adapt their new really quality of life. They feel better, fewer stomach problems, and improved appetite. And then balance that off where the weight gain does not continue forever. Just to mention, there were a couple of other drugs that I think will not have as much use in the future. There was a combination ivacaftor and lumacaftor, and an ivacaftor and tezacaftor, which had not as powerful change in pulmonary function, nor in the GI nutrition phase. So as those came and went, it really leaves us with the ivacaftor and, as I mentioned, this new triple therapy, Trikafta, as the two drugs that are considered highly effective, and I think we'll be seeing more and more use of as time goes on. And these are clearly showing improvements in BMI and weight. And it's really a little bit too early to tell how powerful it will be in improving the short stature that goes with CF. Now, I want to put this in a little bit of perspective because we've made real improvements in the growth failure in children with CF, and these are data from the CF patient registry from 2004 to 2019. And you can see the improvement in the weight status that rather than 20% of the patients being under the 10th percentile, it's been cut in half. Height improvement, not quite as much improvement, but clearly 5% less. But to point out that these improvements have been made based on more attention to nutrition therapy. And from this same patient registry, you see that supplemental feeding by gastrostomy tube is about 10% of patients with CF across the US. And that supplemental feeding using oral products is at about 44%. So almost half of the patients are in active nutrition support. And then the last line, just to mention now that more than half of the patients with CF are adults. And we look at the question, are they meeting their BMI goals? And again, only about half of them are. An emerging problem is adults with CF-related diabetes. And as our patients are living longer, that now becomes another component of managing the nutrition and metabolism for our patients. There had been a question about what these drugs were going to do to pancreatic function. And I think the bottom line here is to say in some genotypes and some patients, we do see an improvement, but it's an improvement for the most part in patients who had residual pancreatic function. So here I'm showing some of the data from our small study with 23 subjects that were all gaining mutations. And at baseline, 7 of the 23 had pancreatic function based on fecal elastase. And in follow-up, we saw that 3 of them actually had a real improvement. So 3 out of the 7, using fecal elastase, were able to see a change. And in 1 of those with pancreatic insufficiency, there was no change. And again, I think this is going to go back to very specific genotypes. Those that came into the study who were pancreatic insufficient did not have any change. So we look forward to learning more about this, really, again, related to genotypes. And as treatment becomes possible in younger and younger ages, there may be more patients with residual pancreatic function that will be improved by these drugs. So now I'd like to switch to talking a little bit about the new nutritional therapy, again, in the context of CF, and certainly all pancreatic diseases that are treated with our best treatment now, the pancreatic enzyme replacement medications. We all appreciate that even when we do our best to match the medications to the fat intake, there is residual or incomplete correction of the fat malabsorption. And this was something that I studied along with the inventor, Dr. Yasser, of a new product. When we did the NIH-funded study, it was called Limixorb, or LXS. I'm happy to say now this has moved to be produced again and is available for clinical use, and it's called Encala. The big contribution is that Encala, made from really designed around lysophosphatidylcholine, is a fat source that is lipase and bile acid independent. And to say it a different way, it basically acts as its own micelle and provides very efficient absorption. So here, just to show you a schematic of what this looks like, the LPC, again, is, if you will, the core ingredient. And then it can be designed with selected long-chain fatty acids and monoglycerides. And it, in particular, has focused on providing the two essential fatty acids, linoleic acid and alpha-linoleic acid. So again, able to function without lipase for digestion or bile acids for micelle formation and absorption. So I want to go over a little bit of published clinical data. The original study had patients with CF and pancreatic insufficiency, 110 participants who were school-age children up through adolescence. And the primary outcome was looking at the coefficient of fat absorption, the CFA, where we showed clinically and statistically improved values from 82 to 88. And as this group knows, CFA is really not a clinical test, often, mostly research, but it's also the test that the FDA uses to document the efficacy of the different pancreatic enzymes. So really the best test to use for our question if the Encala improved fat absorption. The secondary analysis was then to look at the subjects with more severe baseline malabsorption, and that's what I'll show you the results from here. So this was then based on comparison of baseline to 3-month visits. And to remind you at this point, this was a randomized placebo-controlled double-blind trial, and the placebo, an active placebo, had the same calories and the same amount of fat, but provided by regular dietary sources of fatty acids. And we were interested in looking at growth, the fatty acid profile. We did some work in choline because it's a very choline-rich product. And at the way this study was designed, we identified the median CFA, which was 88% in this subgroup, and then compared those who had low CFA, more fat malabsorption, to the ones who had more. So here's the CFA results. And if you look on the panel on the left side, you see the placebo and Encala, and just to show you again the background of all 110 patients. And then on the right side, you see the data from the patients with the more severe disease. And in both baselines, you see that randomization worked. There were no differences at baseline. And then at 3 months, you see the increase for the Encala going from 79 up to 86, and it was highly significant. And to mention, during the trial, all the patients remained on their PERT dose, and they were really managed by their home CF centers. Patients came from 10 different centers, all traveled to CHOP for a very intensive inpatient clinical research center study. So those with the greatest need actually had more improvement. Looking at growth, so in pediatrics, you know, the growth outcome is extremely important. And here, looking at the data that shows that even in the 3 months, we were able to document catch-up growth with the weight Z-score and the height Z-score both improving. And of course, if they improved, your BMI is going to improve as well. So this again was in contrast. These are the subjects with the greater need based on their baseline CFA. Now, as a biomarker, use plasma essential fatty acids. Again, looking at the baseline 3-month data, and you see the figure that linoleic acid improved 20% in Encala, the bright blue, alpha-linolenic acid 50%. Now those the two essential fatty acids. And I also put in the gamma-linoleic acid, which also improved, in part because people are often interested in the fatty acid profiles that are associated with reduced inflammation. And the gamma LA is one of those fatty acids. And in the table below, just showing how much of each of these fatty acids are per dose and how it compares with recommendations. So out of the clinical trial into a clinically usable product, a number of things were accomplished by this transition. And to say this is a medical food, an FDA classified medical food, and it's been designed to add to foods and beverages of the patient's choice, and that it is plant-based, gluten-free, non-GMO, and milk-free, so designed not to create other concerns. Just to briefly mention, in the early experience program with some of the first patients who went on Encala, one of the questions that we were all interested in is, I've got all of this sort of science data, but to have some sense of what the patient reported outcomes were in this kind of setting. So 24 patients volunteered to be in this 2-week program. And those that had the more severe GI symptoms, the 8 that had the more GI symptoms, all reported that they had noticeable improvement. And everybody reported that they had some sense of improved digestion and weight gain. So this is what the product looks like. It's dosed by age, but really by how many calories you want to increase. So this is where the dietitian and the doctor really can make some decisions about rate of weight gain that would be desirable. And the broad indications really are for those with pancreatic insufficiency, and that's what their fat malabsorption is based on, like in CF, but also in non-pancreatic fat absorption, and really anything where you have disease-related unintended weight loss. So again, a list all of you would be very familiar with. The exocrine pancreatic diseases here that this might work for. As I mentioned, this also is bile acid independent, so it may have a role in malnutrition with those with liver disease, and also with some of the other things like short gut, inflammatory disease, all of which can give you some residual fat malabsorption after the primary treatment. So I mentioned it's about 100 calories per dose, and that you could think about this in changing from the oral supplements that really replace the whole meal pattern. And this could just add the needed calories. Also, a lot of interest has come up about replacing MCT oil, which is sometimes used as a caloric supplement. This is much healthier fats than MCT. And there's some early experience clinically, and in my study, about 10% of the patients use this with tube feeding. So in summary, there is a new clinical product that's based on structured lipid technology with strong safety and efficacy data, and bile acid and lipase independent. So potentially very helpful in the diseases all of us are involved with caring for. So thank you for that, and I look forward to the discussion period.